We are live in YouTube. We are live in YouTube. And we are going live. 5, 4, 3, 2. We are now live.
For joining our monthly Pediatric Neurosurgery Zoomposium. So today we're going to speak about diffuse infiltrating pontine glioma, advancing understanding and therapy. This is one of the disease processes that we as neurosurgeons, as neuro-oncologists, we just have not been able to get a handle on. And so I'll pass it over to Dr. McCrae to go ahead and introduce our two speakers today. So thank you.
So as Dr. Niazi said, I think this is one of the most frustrating diseases we treat as pediatric neurosurgeons because we don't have good therapies, and I think also extremely frustrating for neuro-oncologists. So it's for that reason that I'm so excited about the two speakers that we have today, because they're both working to make tremendous advances in this field. And so we're hopeful that in the future, we will have much better options for these patients. First, we're going to hear from Dr. Amanda Siratzis. She was previously at Lurie Children's Hospital and is now going to be moving to Indiana University School of Medicine, where she'll be the associate professor in the Department of Neurological Surgery, Biochemistry, and Molecular Biology. And she's going to talk about some of her basic science work. And then Dr. Michelle Manji is joining us. She's the Associate Professor of Neurology and Neurological Sciences at Stanford University. And though she's done both incredible basic science and translational work on DIPG, she's going to talk to us today about some of her translational work, which really offers more hope for these children. So with that, we'll get started. I urge the audience to please use your chat function to ask questions. We'll wait till the end of both talks to ask the questions, but the goal is for this to be interactive, so please ask away.
Okay, can everyone see my screen?
Yep.
No? Okay, great. So thank you, Heather and Toba, for the opportunity to present today. I'm so honored to be able to talk about the work that we've been doing at Northwestern over the years, and also to be partnered with Dr. Manji today, who's just a professional idol of mine. So this is really a tremendous joy for me as well to be able to participate in this forum. So as Heather alluded to, I'm going to be talking about elucidating the epigenetic landscape of pediatric high-grade glioma, which is really a formidable challenge in the world of pediatric neuro-oncology. So this audience is probably well aware pediatric brain tumors are the most common solid tumors in childhood. There's about 4,500 new cases per year in the United States, making it the second most common pediatric cancer after the hematologic malignancies. It's also the leading cause of cancer death in children. Now, of pediatric brain tumors, the majority are gliomas, and approximately 30% of these are considered high grade. These have the highest mortality of all pediatric solid tumors, where nearly all children succumb to their disease. These tumors have a characteristic radiographic and histopathologic experience akin to adult gliomas. However, they are molecularly distinct from the adult tumors, and they're molecularly distinct by tumor location, meaning the supratentorial versus the midline tumors. Clinical management includes maximal surgical resection where possible, although tumor margins and midline lesions pose a significant challenge for this. Children are given a range of chemotherapeutic agents, plus or minus radiation therapy, but the efficacy of these modes of therapy are limited by the toxicity of the drugs, as well as the difficulty of delivering across the blood-brain barrier. This leaves us with 5-year overall survival of less than 20% for these children, with gross total resection having a survival advantage over subtotal and biopsy. Now, of the high-grade gliomas, the really most formidable challenge here is the diffuse midline gliomas. These are infiltrative glioneoplasms that arrive in the thalamus or the brainstem. When in the brainstem, they may be called diffuse intrinsic pontine gliomas, or DIPG, and these account for 80% of pediatric brainstem gliomas. Management of these tumors includes stereotactic biopsy where appropriate, and then radiation therapy, which gives these children a honeymoon period of about 6 months of symptom-free survival. However, there's no effect on overall survival for these children, which is about only 18 months. These tumors have a near 100% mortality, which makes it the highest mortality of all pediatric cancers. So what is the problem that we face here? You know, there's really been no change in the overall survival for these kids, despite 40 years of very hard work from the neuro-oncologic community. And why is this? Well, there's a diminished access to specimens for molecular study, given the location of these tumors and the fact that it's not a surgical disease. Limited analysis of tumor tissue, our failure to discern this distinct tumor biology or failure to assess the fact that its biology is different than the adult form of the disease, and our discovery that adult treatments do not change the clinical outcomes in pediatric high-grade glioma. There's also a disproportionate amount of funding that's afforded to pediatric cancer research relative to adults. So all of this together mandates a real paradigm shift in our approach to the study and treatment of this disease. But there is hope on the horizon, and I hope to leave our audience today with a sense of this hope and the accomplishments that we've made over the last 10 or 12 years. Some of this is secondary to technological advances, improved access to clinical specimens for study as a result of stereotactic surgical approaches that we can now do safely for these children, the formation of multiple research consortia for specimen and data sharing, the advent of really advanced next generation sequencing and bioinformatic technologies, computational power that allows us to wrangle large data sets and share them across platforms and across institutions, really getting people out of their silos and starting to share their work and make advances that way. And all of this together has led to an increased understanding in the tumor biology. As I mentioned, these pooled sequencing data led to molecular subgroup discovery of these tumors and identification of key molecular features that are unique to diffuse midline glioma. And this I'm referring to the H3 mutations. So the importance of these findings were recognized in the 2016 WHO classification of CNS tumors, which defined these H3K27M mutant tumors as WHO grade 4, regardless of histopathologic features. And what is the H3K27M mutation? This is a recurrent heterozygous sense mutation in one of two isoforms of the histone H3 protein, or the genes that encode the histone H3 protein. It results in a critical change in regulatory amino acid residues, either a K for an M for a K in up to 80% of diffuse midline gliomas, and arginine or valine for a glycine in up to 50% of supratentorial. Why is this important? Well, we've discovered that this actually represents a clinically distinct subgroup of pediatric high-grade glioma patients that have a poorer response to therapy, they have poorer overall survival, and it tends to affect younger children. So there's really something unique about the biology of this disease and the presence of this mutation. So my group and others have shown that H3K27M mutant tumors have molecularly distinct profiles. They have distinct protein and gene expression. They have distinct DNA methylation profiles. They have distinct associated mutations depending on the location of the tumor. And they have alterations in their H3 post-translational modification profiles. These modifications are rendered by histone modifying enzymes, which either place or remove these moieties, either methylation, acetylation, phosphorylation, or ubiquination. And these, in effect, alter chromatin structure and function. And when we have the K27M mutation, there's a change at that K27 residue such that we can't trimethylate as usually done, which is a silencing mark. And instead we get an acetylation, which I'll show you in future slides. These changes of the K27M residue actually have kind of a global effect on both the mutant and wild type proteins in these tumors, which I hope to convince you is biologically important. So given the distinct clinical and biological features of H3K27 and glioma, we aim to elucidate the tumor epigenetic landscape and 3D genome structure of these tumors and explore these features as novel therapeutic vulnerabilities. So this is an overview of our work to characterize the epigenetic landscape in 3D genome pediatric glioma. So today I'll discuss our work to identify novel epigenetic therapeutic targets, our application of novel proteomic analysis techniques to better understand histone H3 structure and function, our use of integrated sequencing techniques to identify chromatin structure, and lastly, our projects focusing on detecting the H3K27M mutant DNA and protein in liquid biopsy specimens. So to begin, let's take another look at the rationale behind epigenetic targets for diffuse midline glioma. The H3 N-terminal tail is notable, as I mentioned, for post-translational modifications at key regulatory amino acid residues, which are either activating or repressing gene transcription. These modifications are rendered by histone-modifying enzymes, which place and remove these modifications along the N-terminal tail. The H3K27M mutation causes a loss of the K27 or lysine residue on the mutant protein, which is typically trimethylated to silence gene expression. So interestingly, the mutation is also associated with a global loss of trimethylation and a relative gain of acetylation on the K27 residue of residual wild-type histone H3. The net effect of this is a loss of repression of tumor oncogenes and silencing of tumor suppressor genes. Thus, targeting this process represents a viable therapeutic strategy against pediatric gliomagenesis. So one example of this is the BET bromodomain proteins. We published this work a few years ago looking at the efficacy of bromodomain inhibition for DIPG. Now, these BET bromodomain proteins are chromatin-associated proteins and histone acetyltransferases. So these recognize the K27 acetyl moiety and recruit RNA polymerase to that location to promote transcription. As I mentioned, the K27M mutation is associated with increased genomic H3K27 acetylation. So we hypothesized that bromodomain inhibition may represent a rational strategy for treatment of these tumors. So as I mentioned, we published this data a few years ago now, where we showed that there are actually heterotypic nucleosomes in the H3K27M mutant cells. This means there's co-localization of the mutant and wild-type proteins in the same nucleosome. We show that this is associated with enrichment of active chromatin marks, including the K27 acetylation, as well as RNA polymerase II. And interestingly, the exclusion of polycomb repressor complex 2 components, including CISI12 and EZH2, and as well as K27 trimethyl, which is concordant with other people's findings prior to this paper. What was new in this paper is we found co-localization of the K27 acetyl marks with bromodomain 2 and 4. We found these at active enhancers as marked by K4 monomethylation and K27 acetylation. And so again, this suggested a possible role of the bromodomain proteins in Dipg pathogenesis. So we took a look at this in vitro, and when we treated the cells with bromodomain inhibitor JQ1, we saw decreased cell proliferation and survival and direct inhibition of bromodomain gene targets, including MYC. We saw cell morphologic changes and gene expressions promoting a differentiation to a neuronal phenotype as well. We tested the strategy in vivo, and we saw reduced tumor size and prolonged animal survival, as well as reduction of tumor burden, cell mitosis, and H3K27 acetyl enrichment with JQ1 treatment. So in future, we're looking to establish a clinical trial of bromodomain inhibition for pediatric high-grade and diffuse midline glioma. And my lab is looking at changes in H3 proteoforms after bromodomain inhibition as a potential biomarker of response to treatment. So next, I'd like to share some novel methods we're employing to evaluate tumor epigenetic signatures. One such approach is the histone tail-focused mass spec. This technique allows us to characterize the relative abundance of 96 distinct modification states all at once, yielding an epigenetic signature or histone code. We use this technique to analyze a cohort of glioma tissues and patient-derived glioma cell lines, as well as normal human astrocytes. We evaluated the effects of in vivo and in vitro bromodomain inhibition on histone codes and relative abundance of various modification states compared between specimen types and therapeutic conditions. So first, on unsupervised analysis, we observed clustering of cell line and tissue post-translational modification profiles, or histone codes, on the basis of H3K27M mutation status. Here on these heat maps, the mutants are highlighted in red. Next, we identified specific patterns of histone post-translational modification states along the N-terminal tail, with differential modifications by mutation status. Using our technique, we were also able to, for what we believe is the first time, quantify the relative abundance of wild type and mutant H3.3 peptide in these cell lines and tumor specimens. We next questioned how bromodomain inhibition would affect histone H3 peptide abundance. Unsupervised analysis of post-translational modification profiles of treated cells revealed clustering by treatment condition, reflecting distinct modification states with JQ1 treatment. Specifically, the relative abundance of 26 distinct individual modification states were found to be statistically significantly different after bromodomain inhibition compared to controls, which are listed in this table to the left. These included fold change in percent relative K27 and K36 acetylation on wild-type H3.3 peptides across cell lines. So moving forward, we're working to evaluate the utility of targeting H3K36 dimethylation in combination with H3K27 acetylation as a novel treatment strategy for diffuse midline glioma. We're also employing additional novel therapeutic techniques, including a top-down proteomics approach, which enables quantification of intact proteoforms and a wider range of post-translational modifications along the entire proteome. So now switching gears, the next portion of my talk will focus on 3D genome structure in pediatric high-grade glioma. Now, as a reminder, DNA wraps around the histone core of the nucleosome to constitute chromatin. Chromatin then condenses and can loop into 3D structures known as topographically associated domains, or TADs. These TADs bring distal gene elements in proximity to one another, such as promoters or enhancers with distal gene bodies, to augment transcription. So we were curious to see how these structural elements play a role in pediatric high-grade glioma and to what extent the K27M mutation may affect these 3D genomic features. To do this, we analyzed a cohort of pediatric glioma specimens, including cells and frozen tissue, and we performed what is, to our best knowledge, the first integrated RNA-seq, ChIP-seq, genome-wide chromatin conformation capture, or Hi-C, and tissue attack-seq analyses. So first, principal component analysis of our whole transcriptome data shows clustering of cells, gene profiles, and technical replicates and diagnosis. We saw two distinct groups of DIPGs clustering independently from GBMs and normal cells. And here we see the DIPGs clustering distinctly from GBMs and normal cells. Next, we identified sets of differentially expressed genes between DIPG, GBM, and normal cells. Some of these included high differential expression of SOX2 and OLIG2 in DIPG. Unsupervised hierarchical clustering of RNA-seq data on the left and genome-wide H3K27 acetyl ChIP-seq signals on the right revealed tumor-specific clustering by sample types, with cell lines and tissue clustering within groups with each other. Importantly, these two heat maps demonstrate similar clustering of transcriptome and K27 acetyl landscapes, suggesting that the K27 acetylation pattern plays a significant role in gene expression in these tumors as expected. Indeed, when we look at patterns of genomic enrichment for K27 acetyl across our cell lines, we see significant enrichment at distinct enhancer regions in DIPG compared to GBM wild type and H3G34 mutant cells. In addition, the K27M protein co-enriched with these distal enhancer signals in our DIPG cell lines, which was consistent with our prior findings of the mutant protein binding at active genomic regions. These representative genome browser views demonstrate distinct patterns of K27 acetyl enrichment in DIPG and GBM specific enhancers. These enhancer data also revealed enrichment of tumor type specific transcription factor motifs and distinct biological processes represented by the differentially bound enhancers between tumor types. So next we generated high-C maps of DIPG and GBM cells and compared these to normal astrocytes. These revealed DIPG and GBM specific TAD boundaries with more TAD boundaries gained in tumor compared to normal astrocytes and in DIPGs compared to GBMs. We also observed greater loop lengths in DIPG compared to GBM as seen in this graph. Aggregated signals from DIPG and GBM specific loops revealed predominantly promoter-promoter interactions between tumor types compared to enhancer-enhancer or enhancer-promoter interactions. Importantly, we found DIPG specific 3D dimensional features. These included greater DNA interaction in frequency and intensity, as well as subtads around the MYC-N region in DIPG compared to GBM in normal cells. This is a genome browser view of this region, which clearly demonstrates a greater number of loop structures in the DIPGs in pink compared to the GBMs in the normal cell lines in blue. Well, prior studies, including my own and the work of others, have implicated MYC signaling in DIPGs, so these data may shed some light on the mechanism of this observation. We also found DIPG-specific DNA loops linking the OLIG2 promoter with a distal enhancer within a distinct gene body that was not observed in GBM or normal cells. Here you can see these loops in DIPG, and they're absent in the GBM and normal human astrocytes. We also saw on our attack-seq signals revealing higher chromatin accessibility in the OLIG2 region in DIPG compared to normal brain tissue from the same patient. Now, OLIG2 is known to be highly expressed in pediatric high-grade glioma and may also play a role in gliomagenesis. So we integrated these data to determine potential relationships between the epigenetic and structural features with gene expression profiles. And as expected, DIPG-specific promoter enhancer loops overlap significantly with DIPG-specific highly expressed genes. In the network shown here, the color overlay indicates the presence of H3K27 acetyl enrichment in purple and the absence of K27 trimethylation in blue. At enhancers of highly differentially expressed genes in DIPGs compared to GBMs. So next, we integrated copy number variation, H3K27 acetyl and H3K27M chip-seq, high-C and attack-seq data, and identified multiple novel enhancer hijacking events in DIPG cells. For example, an inversion and deletion event, as well as a copy number gain, was observed over the SYBU region, which is shown here. We also observed an inversion and interchromosomal translocation at the A2M gene. This novel translocation between chromosomes 8 and 12 was evaluated in DIPG cell lines using FISH, and we're currently working on validating this in tumor tissue as well. So taken together, these findings show that genome structural variations and enhancer promoter interactions impact gene expression in pediatric high-grade glioma and may contribute to pediatric gliomagenesis. As such, further studies examining the impact of these alterations are underway. So far I shared evidence that the K27M mutation has vast genomic and epigenetic effects in pediatric glioma that we're still working to understand. The next question is, how does this understanding translate to better therapies for kids with these tumors? For example, what is the utility of detecting the H3K27 mutation and its epigenetic effects for prognosis, stratification of clinical trials for targeted therapies, and measurement of treatment response? So one avenue that my group is looking into is using K27M mutation detection as a biomarker of disease. it's well known that tumor-derived biomarkers reflect brain tumor biology, and these may be proteins, nucleic acid, extracellular vesicles, circulating tumor cells themselves. And these may be accessed in more clinically accessible specimens relative to brainstem tissue. So the hypothesis is that potentially monitoring these circulating biomarkers, which is also sometimes called liquid biopsy, may be superior to repeated tissue analysis for this purpose. So to this end, my group was the first to demonstrate detection of tumor-specific proteins in CSF from children with brain tumors, including diffuse midline gliomas. We looked at a cohort of 11 high-grade gliomas, including 10 DIPGs, 1 GBM, and then 4 normal controls, using a traditional bottom-up proteomic technique. And we identified tumor-specific proteins in the CSF from children with high-grade gliomas, 71% of which were secreted, and differential detection in tumors versus the normals. We then went on to validate some of these proteins in the tumor tissue, as well as in serum and urine of these children. So again, looking at whether these would be potentially clinically accessible biomarkers for the presence or absence of this tumor. In addition to secreted proteins, my group was also the first to demonstrate detection of the K27M mutant DNA in cerebrospinal fluid from children with glioma. In this study, we sequenced the H3F3A gene in DNA extracted from the CSF from a cohort of glioma patients and normal controls using conventional and nested PCR with custom mutation-specific primers, followed by Sanger sequencing of the PCR product. And what we found was indeed the H3F3A mutations are detectable in circulating tumor DNA with a specificity of about 60% and a sensitivity of 60% and specificity of 100%. We also, of note, found the H3G34V mutation in the supratentorial GBM specimen that we tested. And again, no detection in the wild type controls. Of note and of interest and relative import to the neurosurgeons in the audience, we found higher circulating tumor DNA detected in closer proximity to the tumor and with our nested PCR techniques, which really has implications for collection and incorporation of this approach into clinical trials. Meaning, you know, I know there are some trials where they're doing lumbar punctures versus Ommaya taps for CSF analysis. And really, we have to be very thoughtful about kind of where we're collecting from and why, and I'm thinking about kind of the yield of what we're looking for anatomically. So given these findings, we next sought to kind of increase the sensitivity of our circulating tumor DNA detection. As I mentioned, it was only about 60% with traditional Sanger sequencing. So to do this, we used digital Droplet Pcr, which is a technique that allows for mutation sequencing in very low starting concentrations of DNA using picoliter-sized droplets. It also allows for quantification of the detected mutations in a readout known as a mutation allele frequency, or MAF, and enables multiplexing of multiple mutations in a single specimen, which is of interest in this tumor. So we joined forces with colleagues at the University of Michigan and Children's National Medical Center and asked the question, can we validate this approach on multiple instruments, multiple commercially available instruments, using multiple different primer and probe sets with multiple different specimens that we kind of mailed to one another and analyzed in multiple different places to see if this is really a reliable source of information. And what we found is that it is. We found that ddPCR increased our sensitivity exponentially for detecting this mutation. We found that using a technique of DNA preamplification prior to ddPCR analysis increased our detection with no false positive. And we found similar MAFs for each assay and each instrument that we used. We tested our detection sensitivity with the serial dilutions and found that we could detect the circulating tumor DNA in concentrations as low as 0.3 picograms per microliter. We found that mutations were also detectable in tumor-matched tissue, CSF, and plasma with both platforms, but there's greater sensitivity on the rain dance instrument compared to the BioRad instrument. And here's a readout on the BioRad instrument just to show you what this data looks like. You can see there's 3 different DIPG patients that were analyzed. We can detect these orange mutant droplets and very well in the tumor tissue, strongly in some of the CSF specimens, and pretty strongly in one of the serum specimens. So this was really interesting and important work, and I think, again, has implications for how we incorporate these approaches into future clinical trials. So already, as I mentioned, there is planning for incorporation of CSF analysis into clinical trials. One is in the study of the Valetimics trial, a phase 1/2 study. My group is going to be doing CSF analysis and blood serum analysis for the mutant protein in children that are receiving this treatment. as well as the monoclonal antibody 8H9 against the B7H3 work that Mark Sudane is doing in New York, and the phase 1/2 study of ONC201 that Carl Koschman is doing in Michigan. And really, we have consortia level trial design discussions on a monthly basis amongst our colleagues, this phone call that we have with the DMG ACT group, we call ourselves. And we really discuss on a monthly basis kind of when should we be sampling CSF or blood? Where should we be sampling from? Is there a role for indwelling CSF access devices or neurosurgeons in these clinical trial designs? And how do we correlate these findings of these different amounts or abundances of the mutant DNA with our imaging in the clinical course of these children? So these are all data that we're prospectively collecting and analyzing, and questions that we're actively addressing right now. And I urge anyone who has any interest to reach out to me to discuss this further if you have ideas, because I think this is really important work that can potentially make a big difference for these kids. So what are our next steps in the lab? We're doing integrated proteogenomic analyses where we're looking at paired human tissue and liquid biopsy specimens. We're looking for cellular and secreted proteins. We're looking for the mutant DNA as well as histone H3 proteoforms, and doing a lot of mechanistic work looking at some of these epigenetic targeted therapeutic agents. And one thing that I do want to touch upon, which kind of hopefully will transition into Dr. Manje's talk, is drug delivery. And I don't have time to talk about it too much right here, but another project that my group is embarking on is ultrasound-mediated blood-brain disruption for improved drug delivery in pediatric high-grade glioma. And one of the questions that we're really interested in asking is, how does drug distribution change with use of ultrasound? How does treatment efficacy change with use of ultrasound? And how do the concentrations of detected tumor proteins and circulating tumor DNA change in response to blood-brain barrier disruption? So these are all questions that I hope to be able to answer in the coming years with some of these studies that we're doing in our lab. So I hope I convinced everyone that pediatric high-grade glioma is a biologically distinct disease. It's known to be characterized by a high rate of histone mutations, and it has a unique epigenomic and 3D genomic landscape, which has implications for how to treat these children. I think clinical detection of biomarkers of tumor biology could potentially improve pediatric high-grade glioma management. This includes tumor DNA and proteins, looking for epigenetic signatures or histone codes, with really the opportunity for longitudinal clinical monitoring of these children and improvement of their treatment. So I want to thank you for the opportunity again to address this group this evening, as well as to thank my lab, my collaborators, funding sources, and of course the patients and families that supported this work. Thank you.
So now we'll switch over. That was a great talk. So now we'll switch over to Dr. Manje and her talk, and then we'll do questions for both at the end. Thank you very much.
Hi, my name is Michelle Manje. I'm a pediatric neuro-oncologist and a basic neuroscientist. And I've been studying DIPG really since I first encountered it in medical school. So I'm really pleased actually to share with you some translational and early clinical work from my laboratory in collaboration with many, many people, importantly, Crystal Makel and Robbie Majner and others who I'll highlight along the way of the talk, in which we have been working to develop GD2 CAR T cell therapy for H3K27M positive DIPG and spinal cord DMG. So as Dr. Saratsas just so beautifully introduced, a unique family of high-grade gliomas of childhood and young adulthood include these H3K27M mutant high-grade gliomas of the brainstem or DIPG, of the thalamus, and of the spinal cord. These are diseases that we've really made very little clinical progress for really since the introduction of radiation therapy over 40 years ago. And part of why we have made so little progress until very recently is that there was this false assumption that this disease was biologically similar to adult GBM. And we now know that it is a vastly different pathophysiological mechanism. And part of the impairment in making any progress has been lack of experimental model systems to test new therapies. And that really began to change a little over a decade ago as patients began to donate their tumors either during stereotactic biopsy or at the time of their passing. And from these really invaluable tissue gifts, we've started to be able to study DIPG and other diffuse midline gliomas in vitro, in mice. And this has really opened up a wealth of new knowledge about the disease. This is a former MD PhD student in my lab who's now a neuropathology resident at MGH, and named Chris Mount. And when Chris was in my lab, as we were receiving these incredibly valuable tissue gifts for culture, we began discussing an unbiased screen of the cell surfaceome. And so as a side project, Chris decided that he would perform a screen of what antigens are present on the surface of DIPG cells. And so taking a panel of patient-derived DIPG and then later spinal cord and thalamic cell cultures, we found that there was extraordinarily high and fairly uniform expression of this sugar moiety of a disialloganglioside called GD2. And so looking at these different patient-derived cultures, you can see that in comparison to control, these red traces show you that there's very high, very shifted over to the right, and very uniform, very narrow peaks expression of GD2. And this was really a striking finding because over the last couple of decades, a number of different immunotherapeutic strategies have been developed against GD2 because it's a molecule that's also highly expressed in other childhood malignancies like neuroblastoma. And around the time that we had this discovery in the lab, Crystal Makel, who's really pioneered CAR T-cell therapy for childhood malignancies, moved to Stanford from NIH and had just developed a new GD2 CAR T-cell construct. And so it turns out her office was around the corner from mine. I knocked on her door, I think, with this printout, and we've been collaborating ever since. And so this is Crystal Makel, a postdoctoral fellow in her laboratory at the time, now an assistant professor at Stanford, and someone who is co-leading this trial with me is Dr. Robbie Meisner. And Dr. Meisner and Chris Mount in my lab took these CAR T cells and treated our DIPG mouse models with them. And what we found was that in comparison to a non-targeting CAR T cell, a control CAR T cell that we would not expect to react with DIPG or other gliomas, the mice that received the GD2 CAR T cell just had sort of disappearance of their tumors between 7 and 14 days after IV infusion of the CAR T cell. And I have to tell you, I've been working with these xenograft models now for over a decade. I had never seen anything like this. I actually didn't even believe it when I first saw this data. I asked poor Chris and Robbie to repeat this experiment a number of times. But again and again, what they brought me was data showing that between 7 and 14 days in multiple different patient-derived models of DIPG and spinal cord DMG, that these tumors were just eradicated. And when we look at the T cell trafficking, we see that it begins to emerge around 7 days in the meningeal vasculature after IV administration. Here you have these green tumor cells in the middle of the medulla of a mouse. And by 14 days, the CAR T cells have infiltrated the tissue and the tumor is gone. This is seen at multiple levels and in multiple different experiments. These green and, in this case, green and purple tumor cells infiltrating the brainstem of a mouse are eradicated. Now, this was incredibly encouraging, and the mice that survived the therapy, for all intents and purposes, as far as we can tell in the laboratory, were cured. But I want to point out that not all mice survived the therapy. So some mice were lost during the active inflammatory phase. And what we determined was happening was that during that active inflammatory phase, the mice were developing hydrocephalus. And that is something that, is clinically intuitive, as you have an already expanded brainstem that is then inflamed and edematous. It can compress the fourth ventricle or the cerebral aqueduct and cause a backup of CSF flow or obstructive hydrocephalus. So our mice were, not in any kind of mouse ICU. They were downstairs in the animal facility. But this was really informative because we know how to treat hydrocephalus, and we now knew to anticipate it and prevent it in the clinical trial, which I'll tell you about in just a moment. Encouragingly, because there are low levels of GD2 expressed in normal brain and peripheral nerve tissue, we did not see any off-tumor reaction of the CAR T cells. All of the normal brain looked histologically intact. Thinking about other histone mutant diffuse midline gliomas, when we tested GD2 targeting CAR T cell therapy against H3K27M spinal cord gliomas, we similarly saw clearance of the tumors. But when we did this for thalamic DMGs xenografted into the thalamus, while we saw clearance of the tumor, none of the mice survived. And I think that really highlights the extraordinarily precarious location of these bithalamic diffusely infiltrative tumors and the high potential for transtentorial herniation. And so for the clinical trial, we have for the moment excluded children with thalamic gliomas until we have a better handle on how to deliver this therapy safely. And so, thinking about translating a therapy, the GD2 CAR T cell therapy was an attractive one because there is consistently high expression of GD2 on H3K27M mutant tumors. And I want to just underscore that it is really the mutant tumors that express this. And it's because of the histone mutation-induced epigenetic dysregulation of GD2 synthesis genes that this antigen is so extraordinarily highly expressed on the cell surface. We saw this really striking efficacy in preclinical models, and while it is certainly easier to cure a mouse than to cure a child, this was a good place to start. And we wanted to translate this, but really carefully, because inducing inflammation and consequent edema in these precarious midline brain regions really requires very thoughtful approach. And so after some planning and sort of building a multidisciplinary team between neurosurgery, neurocritical care, neuro-oncology, critical care neurology, we opened last June, actually just 1 year ago, this phase 1 clinical trial of autologous GD2 chimeric antigen receptor T cells for H3K27M mutant DIPG and spinal cord DMG. And I want to just introduce, this is a big team of people that are required to execute this trial. It's really been a wonderful team effort between neuro-oncology, cancer cellular therapy, and of course our neurosurgery colleagues and neurocritical care colleagues. And so the overall structure of the trial involves once eligibility criteria are met, harvesting T cells from the child and then manufacturing the CAR, the chimeric antigen receptor expressing T cells through retroviral induction of the T cells. During the time that we're manufacturing the T cells, we're placing an Ommaya reservoir in each patient. And the initial reason to place the Ommaya reservoir was to monitor intracranial pressure and be able to treat hydrocephalus should it develop urgently. What we've learned from our first few patients on the trial, and which I'll describe in detail in a minute, is that we can re-administer CAR T cells directly into the Ommaya. And that appears to be a very promising route of administration as well. Having the Ommaya in place as a secondary reason for placing it also gives us access to the CSF space and the lateral ventricles and allows us to monitor the cellular composition at the single cell level, CSF cytokines, cell-free DNA, et cetera. For the IV administration arm of this trial, which is what we started with, there's a standard lymphodepleting chemotherapeutic regimen with fludarabine and cyclophosphamide, followed by 1 day of rest, and then IV CAR T cell infusion. And we have 3 different dose levels, 1 million cells per kilogram, 3 million cells per kilogram, and 10 million cells per kilogram. We've just completed the first dose level. We're in the midst of the second dose level. So I'll tell you about how the patients on the first dose level have done. Then patients are kept in the hospital, actually for a fair bit of this time in the pediatric intensive care unit for intensive monitoring for potential toxicity. And what are we monitoring for? Well, as with any CAR T cell therapy, we're monitoring for cytokine release syndrome. As with any CAR T cell therapy, we're monitoring for the sort of neurological syndrome that can go along with cytokine release syndrome called immune effector cell acute neurotoxicity syndrome, or ICANS, which typically is characterized by confusion, altered levels of consciousness, and sometimes aphasia and ataxia. And then specific to immunotherapy for central nervous system tumors, we're monitoring for tumor inflammation associated neurotoxicity. And because everything in medicine needs an acronym, we're calling that TN. So there are two types of, two classes of TN that we worry about. Number one has to do with space limitations. So the inflammation-induced edema can cause expansion of an already, expanded by tumor structure. It can increase intracranial pressure, it can obstruct CSF flow, and it can induce dangerous tissue shifts. So this is something that is an emergency and may require, neurocritical care, even neurosurgical management. Type 2 TN is about the inflammation-induced dysfunction of the part of the brain or spinal cord that is involved in the inflammatory process. And so this really reflects neural circuit dysfunction and is characterized by typically transient worsening of existing deficits or even new deficits, followed by resolution and hopefully improvement from baseline. The Ommaya catheters that we're placing in all patients allow for intracranial pressure monitoring, treatment of hydrocephalus, and monitoring CAR T-cell trafficking, as well as brain inflammation, and has the additional benefit of allowing us to give potentially additional doses of GD2 CAR T cells through the Ommaya if there is benefit but incomplete benefit from the IV infusion. And as I'll begin to talk about, we're finding that these repeated infusions have been really important. And then the correlative studies that we're doing include a 50-panel cytokine analysis. We're doing 10x single-cell sequencing of cells isolated from the CSF, as well as sequencing of the CAR T-cell product. We're looking for ctDNA using the protocols developed by Dr. Saratzis, and doing additional biochemical analyses of the CSF. So in the first dose level, just to summarize, what the clinical experience has been so far, the first patient that we treated was treated at the time of early, she was in early progression by the time we had made her CAR T cells and treated her. Of the 4 patients, she exhibited the least benefit, unfortunately. She had stable disease at 1 month, and then her progression continued rapidly, and she passed away 3 months later. The second patient was a second DIPG patient, was treated again by the time we made the CAR T cells in early clinical progression, kind of underscoring how quickly this disease tends to go. He exhibited radiographic and clinical improvement at 1 month, stable disease at 2 months, and then progressed at 3 months. And as I'll describe in a moment, was retreated intracerebroventricularly through the Ommaya catheter and had a remarkable response then. The third DIPG patient was treated prior to the time of progression, exhibited both radiographic and clinical improvement at 1 month with continued improvement by 2 months, but then progressive disease in the cerebellum by 3 months, and was also retreated. The spinal cord diffuse midline glioma patient treated at this dose level actually presented in early progression, and by the time we made her cells, so between the time of apheresis and planned cell infusion 3 weeks later, she had progressed so rapidly that she went from walking to complete paraparesis and in so much pain that we took her off trial. Did a duroplasty to treat her pain, and then treated her on an emergency IND. So we gave her cells, but on compassionate use basis. She had a marked therapeutic response in her spinal cord, but not in a brain metastasis that we discovered. So I will discuss both that heterogeneity in response as well as her case in some detail. So of the 4 subjects, all exhibited cytokine release syndrome very consistently between day 6 and 7, each spiking high fevers and then variable degrees of other severity cytokine release syndrome with tachycardia and blood pressure decreases responsive either to IV hydration or in one case requiring pressor support. One of the 3 subjects, one of the 3 DIPG subjects exhibited type 1 tumor inflammation-associated neurotoxicity and hydrocephalus requiring intensive management. There were no DLTs that were observed on dose level 1, and 3 of the 4 subjects treated experienced meaningful clinical improvement. 3 of the 4 subjects were then retreated with a second dose of CAR T cells that were administered intraventrically. So let me take you through each of these patients in some detail in the next 12 minutes that I have. The first DIPG patient was a 14-year-old girl with DIPG. She had been treated with radiation and panobinostat over the course of a year. We administered 1 million cells per kilogram infused IV on day 0, and by day 2 to 3, she was exhibiting worsening of pre-existing symptoms. We transferred her to the ICU for closer monitoring. By day 6 to 8, she had a high fever to 40 degrees centigrade and no hemodynamic instability, so grade 1 CRS. She also had new and increased brainstem signs with new vertical nystagmus, new facial droop. We did an MRI scan that showed increased edema in the tumor, and we gave her tocilizumab to decrease circulating IL-6 levels given the CRS, and began dexamethasone given the concerning new brainstem findings. And then on day 9, she exhibited an acute episode of hypertension, tachycardia, and altered mental status, began to exhibit extensor posturing in both upper extremities, and had a new right hemiparesis. We, within minutes, checked her ICP through her Ommaya and found it to be elevated at 22. CSF was removed with immediate improvement in her mental status and motor function. We increased her steroids and began an anti-interleukin-1 therapy called anakinra. MRI scan showed tumoral edema. We were able to wean the anakinra, but we were never able to completely wean steroids, in part because of tumor progression. She continued to worsen clinically due to tumor progression and passed away 3 months later. She donated her brain at the time of her death. And what we found at autopsy was that there was marked T-cell infiltration of her tumor with no T-cell infiltration in the normal brain. This is very atypical for DIPG, almost has no lymphocytes in most patients. This is really atypical. And we found that many of these T cells did indeed represent CAR T cells. The lack of lymphocytic infiltration in the normal brain really reflects the difference in antigen density between GD2 expression, shown in blue, in the tumor, and GD2 expression here in lighter blue, shown in normal brain. As we're learning through the correlative studies that I'll discuss at the end of the talk, here numerous microglia and other myeloid cells within the tumor may have contributed importantly to her lack of clinical response. As I'll discuss later, she had evidence of a prominent myeloid-derived suppressor cell phenotype within her tumor. The second patient was a 21-year-old male with DIPG. It was diagnosed one year previous to enrollment, treated with radiation and ONC201. He was in early clinical progression at the time of trial enrollment, and also received 1 million cells per kilogram administered IV. He developed on day 7 grade 1 CRS, otherwise tolerated this administration very well, and had improvement of his neurological signs and symptoms, actually improving to a near normal neurological exam, just with a mild left 6th nerve palsy. And you see that before infusion, this is the appearance of his lower pons. You see this relatively large, bulky disease pushing back into the cerebellum that is reduced in bulk at 4 weeks after infusion. He did very well for a couple of months and then began to exhibit progressive disease at 3 months following his first CAR T-cell infusion that was characterized by rapid accumulation of neurological symptoms, worsening of his left, 5th, 6th, 7th, and 8th nerve palsies, new right hemiparesis, right hemisensory loss, and ataxic gait. We brought him back and administered a flat dose of 30 million CAR T cells intra-Ommaya. He had a very early fever on day 2, together with headache, nuchal rigidity, and nausea, vomiting. His ICPs were normal until the evening of day 2, when he suddenly became more somnolent and developed a new 3rd nerve palsy. And when we checked his ICP, it was elevated at 34. Immediate CSF drainage resulted in immediate improvement. His head CT after CSF drainage showed obstructive hydrocephalus due to increased edema within the tumor. We left his Ommaya accessed for, I think, about 2 days, just under 48 hours. He was given a 4-day course of steroids and then was able to be transferred to the floor after deaccessing the Ommaya and weaning off the steroids with a discharge actually pretty quickly by day 11. And he had during this time a pretty marked reduction in his tumor. Here he is in his upper medulla, lower pons, with a reduction at this level by about 50% throughout the tumor. The reduction at 2 weeks, which was over a week off steroids, was about 25%. And his clinical improvement was really quite dramatic. So here I'm showing you an image of the 7th nerve palsy at baseline, resolution of the 7th nerve palsy by 2 weeks. And his gait, I think, really shows how dramatically better his clinical exam became. So here is his gait on the day of admission prior to the second infusion. You see that the gait is wide-based. He has this right circumduction, increased tone on the right, decreased right arm swing. He's going to try to walk back on his toes, and that's incredibly difficult. It really brings out the right-sided spasticity. He's going to now try to tandem walk and actually almost falls. 2 weeks later in clinic, having been off steroids for over a week, here's his gait. Much faster, much more narrow-based. He's able to turn with just 2 steps. Still a little bit of decreased arm swing on the right, a little bit of right circumduction, but marked improvement. And this improvement persisted for about 6 weeks when we brought him back for an additional infusion. The third patient is a 5-year-old female with DIPG. She had a pretty dramatic response to radiation. She had a relatively normal size brainstem, but abnormal T2 signal. So you see here the left cerebral peduncle is infiltrated by tumor. After her infusion, we see this resolution of the signal abnormality. Together with this left cerebral peduncle disease, she had pretty marked right-sided hemiparesis, spastic hemiparesis. This hand was unusable and held in increased tone in a flexed position. Very quickly, by 1 to 2 weeks after infusion, she's able to open her hand. She begins to use it to play. And together with this marked improvement in right-sided spasticity and improvement in the weakness of her right arm and leg, she also had improved balance and coordination. She began to, when she went home after being in the hospital, learn to ride a scooter using her right leg to push off. She also had a dramatic improvement in her chronic nausea, which had been present since diagnosis, began eating very well. She actually jumped 2 growth curves in the first month and grew 5 centimeters. She had improved hypophonia, improved drooling, and when she progressed in her cerebellum, we retreated her. This was kind of a mixed response. We saw further improvement in her brainstem disease, further improvement in her right-sided weakness with new ability to dorsiflex and new ability to extend her wrist, but we saw continued progression in the cerebellum. So in my last 4 minutes, I'm going to tell you about spinal cord patient DMG number 1, who was this 25-year-old with a H3K27M mutant spinal cord diffuse midline glioma. She had been treated with surgery, cord radiation, and enrolled on the trial. As I mentioned earlier, she progressed so rapidly she had to be removed from trial and placed on an emergency EIND. She exhibited grade 3 CRS, but otherwise tolerated the infusion very well. Grade 3 CRS meaning she was on 1 pressor. She exhibited a dramatic response in her spinal cord, which I'll show you in a moment, but not to a metastasis to her brain. She was able to regain motor function to some extent in her legs. She was walking with harness support and physical therapy. She regained independent urinary function after being fully incontinent. But then, like the other patients, progressed at 2 to 3 months and returned to us for retreatment. And I just want to show you her cord over the course of these 2 infusions. So here's the size of her tumor in the beginning. After the IV infusion, she reduced the size of the tumor by about 90% by volumetric measurements. It then regrew at 2.5 months. And after our second infusion, decreased again to about 80%. Her brain metastasis, however, just continued to progress. So we're trying to understand the heterogeneity between patients. We're trying to understand the heterogeneity between locations. Why did the spinal cord tumor progress when the brain tumor did not? We did biopsy that brain tumor. It was the same disease. It did express the antigen. So what's the difference? What are the differences? We've been doing deep correlative studies that I think in the interest of time, I'm going to just go over very, very quickly. But we do see that there is expansion and limited persistence of the CAR T cells. We are losing CAR T cell activity around the time that patients are clinically progressing. But excitingly, we see second responses. And so we're learning that this is a therapy that needs to be given repetitively and at shorter intervals than we initially did. We see CAR T cells tracking to the CSF by single cell RNA-seq after IV infusion. We see, we see expansion of those cells to some extent. We see greater expansion after intra-Ommaya infusion. We see a marked cytokine response detected both in blood and in CSF across the patients. The CSF cytokine response is much greater when the CAR T cells are administered intra-Ommaya. And as to what was different between patient 1 and patient 2 and 3 and spinal cord DMG patient 1, this patient who did not exhibit benefit from the CAR T cell therapy had markedly elevated immunosuppressive cytokines, TGF-beta, in her CSF, as well as by single cell RNA-seq more T regulatory cells and more myeloid-derived suppressor cells. So the trial is ongoing. We've now treated 9 patients, 6 with DIPG, 3 with spinal cord glioma. 8 of the 9 patients have had pretty clear radiographic and clinical improvements to date. And these correlative studies are beginning to elucidate mechanisms that may be modulating response so that we can learn to optimize this therapy. So what are the lessons learned? In the last 1 minute, I want to just highlight that, effective immunotherapy for brainstem disease really requires a closely monitored inpatient setting and a multidisciplinary approach that applies principles of neurocritical care and neurosurgical management. We're encouraged that the GD2 CAR T cells are inducing on-target, on-tumor inflammation with no evidence to date for off-tumor inflammation. Repeated dosing is both tolerated and promising. And in general, the neurological deficits that we have observed are reversible with effective therapy. And I think that is, I've never seen this happen. I've never seen a patient with DIPG who is hemiparetic have their neurological exam return to baseline. It really underscores that this is a tumor that is not primarily destructive. It is primarily integrating into and causing neural circuit dysfunction. And so if we can effectively disintegrate it, there is the real hope and potential, I think, to cure this disease. A durable response will require a much deeper understanding of the tumor microenvironment and optimization of this therapy, likely in combination with others. Many, many people to thank, but most importantly, the patients and their families who participated in this trial, which really required true bravery. Thank you so much for your time.
All right, well, thank you so much for that talk for both of you. So I have several questions coming in here. So I'll start with Amanda. So one of the questions I have for you that somebody in the audience has sent me is, what cell lines were used? Are they commercially available, and what is the cost associated with them? Why not primary cells? And is there a difference in methylation status between primary culture and cell lines? And I'm happy to repeat that for you.
I got it. So we generate, in my lab, we generate our own cell cultures. They are primary cell cultures that we propagate. We don't alter them or immortalize them in any way. So in that sense, they are primary cultures, not lines, and they're available for free. Just pay for shipping. So just email me or my lab manager. The information's on our website, and we're happy to share them.
Okay. Another question is, what is, given the adverse events that you have, what are the limits of this trial? I guess, at what point would you consider something to be an adverse event, enough of an adverse event where the trial would say, it has to halt things? So I guess that was one of the questions I had as well.
Yeah, so, these the toxicities that we've observed have been expected and consented for. So we really don't think that you can do this without potentially causing obstructive hydrocephalus, potentially causing worsening of existing symptoms. So that meant that we had to think very carefully about how to define a DLT. And the neurological DLTs would include something like a grade 4 event that lasted longer than 96 hours. Seeing an irreversible new neurological symptom or sign would be, that was clinically important, would be an adverse event that we would consider, potentially dose limiting. But we're trying to capture, this is certainly not an easy therapy to take. And so we're trying to capture whether by patient reported outcomes, this is something that patients themselves would want to do again, would recommend, and whether they're gleaning, improved quality of life despite, the difficulty of these few weeks that they're undergoing acute inflammation. So far, that has been, very positive from our patients. They've had pretty marked improvement in their neurological functions. But, every person is different, and I think that, the danger of causing inflammation in the brainstem is something that should be taken incredibly seriously. And, when we consent patients for this trial, we're very clear with both the child and in different language with the family that this could result, this is a dangerous therapy. This is very high risk, and really anything could happen.
Okay. Another question with respect to the response, you mentioned you're trying to look at why sometimes the second site is not responding and that they do have the antigen. Do you know yet if they have it at the same levels as the primary tumor? And do you think it's a difference in the immune response, or any ideas of?
I think it's a difference in the microenvironment. They do have the antigen in the couple of cases that we've been able to examine. They do have the antigen. It is at the same level, at least in the limited, experience we've had with actually seeing tissue afterwards. But it happens to be that sites that are not responding, the sites of metastasis, are sites of metastasis. It's not the primary site. Is that a different subset of cells that are interacting with their microenvironment differently and remodeling their immune microenvironment in a different way? Or is it that these are previously unirradiated sites, which certainly influences the microenvironment in a durable way? Does, in other CAR T-cell trials for other solid tumors, responses, for example, in osteosarcoma are only seen in previously irradiated sites, because we know that induces a durable change in the inflammatory state of the myeloid cells in that tissue microenvironment. So I think we have a lot to learn. We're going to go back now and try to model that in the laboratory to make the mouse treatment less effective so that we can, distinguish differences and then look at previously irradiated versus not previously irradiated sites of disease.
That raises another question for Amanda and your data, Amanda. Have you looked at whether there's any difference in ability to pick up the mutations in the CSF with your liquid biopsy work on irradiated versus non-irradiated tumors? Do you have enough sample size to see that?
No, we haven't. We don't. All of the specimens that I have are pre-radiation, actually. But that's really an interesting question. I hadn't thought of that. We look at like the cell media to look at like secreted protein or cell-free DNA in our cell lines post-radiation, pre and post-radiation, but not patient samples.
And it raises another question I'm curious both of your opinions on. I know people have bounced around the idea of whether, if we are biopsying these kids, should we do it pre-radiation or should we do it post-radiation, in terms of whether the landscape is different. Either of you have thoughts on that?
Yeah, I mean, I can go first. Our proteomic data shows that the landscape is different post-radiation. I didn't show that data, I just showed the JQ1 treatment, but we did the same experiment with radiation and it shows that it's vastly different. So I think, both would actually be really, really useful, but to the ethics of being able to biopsy a child twice, it's not there. So in lieu of that, I would say pre-treatment. I'd be interested to hear Michelle's opinion on that.
Yeah. I've studied radiation effects on myeloid cells in the brain, but not in the context of also, DIPG. So we know that there's this, durable change. It's actually quite it's a state change in the resident microglia and an infiltration of peripheral macrophages. So, our hypothesis is that that's going to really affect the microenvironment, but we need to, now empirically test the extent to which that's contributing.
So Amanda, one question for you from the audience is, what is the actual yield of biomarker from the CSF versus plasma? And if high, what is the role of so-called liquid CSF biopsy? It's one of the questions, Amanda.
Sure. So our work and the work of others who do similar work shows that the yield of the cell-free DNA is much higher in the CSF than in the plasma. And it's higher in closer proximity to the tumor, so higher from the lateral ventricles or the fourth ventricle compared to a lumbar puncture. And that's true for protein as well. So, my group actually just wrote a paper kind of advocating for the placement of Ommaya reservoirs in all of these children for integration of CSF collection longitudinally throughout various treatments in various trials. I think it'd be really, really important to do the type of correlative work that Dr. Manje's group is doing with her CAR T cell therapy. It would be really interesting to be able to do that work in other trials as well. But to answer your question, I think, I kind of alluded to the fact that I think neurosurgeons need to get back into the management of DIPG. Now that we're biopsying more, it's starting to be a neurosurgical disease again. And I think there's a role for CSF acquisition as well, and input really needed and management really needed from the neurosurgical team for these kids.
Sure.
I agree wholeheartedly.
So one of the other questions, we have a lot of questions for you guys. Another question I got sent was, what is the real risk of blood-brain barrier focused ultrasound disruption versus the yield and pharmaceutical boost?
So that's the question that we are trying to ask in a mouse model of disease. I can tell you that my adult colleagues at Northwestern are doing these studies in the first in-human trial in adults, and they're finding exceptional results in terms of they're using paclitaxel actually and being able to cross the blood-brain barrier, and really good clinical response with very few side effects. There's very few, if any, side effects of opening up the blood-brain barrier with this kind of bubble therapy that through the ultrasound. So it's really promising. It's really exciting. I know a lot of groups are starting to get on board. Dr. Rutka and his team have been working on this for years. And I think that it's another technology that I think would really be integrated into some of the ongoing trials to kind of repurpose some of the drugs that we've been looking at.
Great.
Another question from the audience for Michelle is on whether there's a thought that treating prior to progression versus after progression, would one of those lead to a more durable response?
Yeah, we certainly would like to treat prior to progression. When you treat after progression, you really can think about it as a race between the rate at which the cells are growing and the rate at which the CAR T cells can fight those cells. And it's really a matter of numbers, right? It's like going to war and having one army be, self-replicating and the other one getting exhausted. We enroll these patients prior to progression, but by the time we've enrolled them and made the CAR T cells a few weeks later, it is not at all infrequent that they've already progressed because this is a very aggressive disease. And so, we allow for early progression on the trial. We are trying to screen and enroll children just after radiation. But this disease is brutal. There was a child that we just enrolled, right after radiation, who had a wonderful neurological exam and a great radiographic response to radiation. And during the time that we were making the CAR T cells, he progressed to the point of being locked in. It was just terrible. This is just a terribly fast disease. So yes, I do think that before progression is preferable. And I think that brings up the important point that other strategies to decrease the growth rate of these tumors, not through cytotoxic means, because you don't want well, because unfortunately there aren't many options for that, but also because you don't want to hit the CAR T cells, but perhaps by disrupting some of the key growth factors in the microenvironment. And there are some very important, which I didn't have time to talk about today, but very, very important biology that drives the growth of these signals. By disrupting some of those microenvironmental factors, we may have the time for the CAR T cells to take better effect. I also think that, now understanding the cadence of the response, that, at least monthly infusions, better tolerated through the Ommaya than IV, less CRS, might be an important strategy. And we've just amended the trial now to start with intracerebroventricular administration and do 6 monthly infusions to see if we can really get on top of this and push forward, since that's so much better tolerated from a systemic standpoint, without really, peripheral inflammation, or not much. We're hopeful that that might be a better approach. Lots of work to do.
Great. All right. Well, I think this has been an excellent. It's excellent to have both of you give these talks today. Let us know about the research that both of you are doing. I want to thank both of you for joining us and giving time out of your day at the end of the day. And we look forward to seeing where the CAR T cell treatment goes and the all of the liquid biopsy from the DIPG that Amanda's working on. So I'm really looking forward to seeing where we are 10 years from now, and I'm hoping that we make some headway. So thank you again.
Great. Both of these were fabulous talks. Thank you so much for joining us today. And it's great that there's finally some hope moving in the direction for these patients who are so hard to treat. So thank you so much for joining in today. For those of you who join monthly, our next session will be on August 9th, and it's going to be focused on global pediatric neurosurgery work.
Okay. Thanks again, guys. Have a great night.
Having us. Bye-bye.